Come back to the Pathoma lecture series. So the next section in the Pathoma is the kidney and the urinary tract pathology. And we will discuss the important pathologies of the kidney and the urinary tract pathology in this discussion. So the first one to discuss is the horseshoe kidney. First we will cover the congenital anomalies, and then we'll go to the acquired. So the first one in the congenital is the horseshoe kidney. Horseshoe kidney actually means the conjoined kidneys usually connected at the lower pole. Most common congenital renal anomaly. So first we will understand the normal physiology, and then we will understand the pathology, that what is the actual problem with the kidney in this case. So normally the kidney form in the pelvis and ascends into the abdomen later. But in the horseshoe kidney, the root of the inferior mesenteric artery, the inferior mesenteric artery do not allow the conjoined kidney to go to the abdomen, so remain in the lower abdomen. So the problem is just because of the conjoinment of both the kidney's lower pole and the inferior mesenteric artery do not allow them to go to the abdomen. So the kidneys is abnormally located in the lower abdomen. Horseshoe kidney gets caught on the inferior mesenteric artery route during its ascent and from the pelvis to the abdomen. The next discussion is the renal agenesis. Absent kidney formation may be the unilateral or the bilateral. As indicated from the name agenesis, the A means not and genesis means no development or the production. So it actually means the absence of the kidney. It may be the unilateral or the bilateral. And the unilateral agenesis leads to the hypertrophy of the existing kidney. Hyperfiltration increases the risk of the renal failure later in the life. The bilateral agenesis leads to the oligohydramnios, means the low amniotic fluid with a lung hypoplasia. Flat face with a low set ears. This is actually the child presentation in case of the renal agenesis. If the agenesis is bilateral, it leads to the oligohydramnios. And the patient will be and the child will present with a lung hypoplasia, having the flat face with the low set ears and the developmental defects of the extremities, which is known as the Porter sequence. Porter sequence including the lung hypoplasia, flat face, and the extremities defects. The next is the dysplastic kidney. Non-inherited congenital malformation of the renal parenchyma characterized by the cyst and the abnormal tissue as the cartilage. Usually unilateral, when bilateral must be distinguished from the inherited polycystic kidney disease. So this is an important point. The next discussion is the polycystic kidney disease. PKD, inherited defect leading to the bilateral enlarged kidneys with a cyst in the renal cortex and the medulla. Mean the cyst is present in both the renal cortex and the renal medulla. This is autosomal recessive and maybe the autosomal dominant. So in the autosomal recessive form presents in infants as worsening renal failure and hypertension. Newborns may present with a Porter sequence, as we already discussed about the Porter sequence in the just recently in the renal agenesis section. It is, if the condition is the autosomal recessive, it is associated with a congenital hepatic fibrosis, which will lead to the portal hypertension and the hepatic cysts. The next is the autosomal dominant, and if the polycystic kidney disease is the autosomal dominant, and the autosomal dominant form present in the young adults as hypertension due to the increased renin, hematuria, and the worsening renal failure. The autosomal dominant form is due to the mutation in the APKD1 or the APKD2 gene. Cysts develop over time. This is associated with the Barry aneurysm, hepatic cyst, and the mitral valve prolapse. So this is high yield that the autosomal dominant form of the polycystic kidney disease will be associated with the Barry aneurysm, hepatic cyst, and the mitral valve prolapse. The next is the medullary cystic kidney disease. Inherited autosomal dominant defect leading to the cyst in the medullary collecting ducts. The parenchymal fibrosis result in the shrunken kidneys, means the shrunken kidneys leads to the decrease the size of the kidneys and worsening the renal failure.